Hey, today we're going to be talking about how the shoulder becomes destabilized other than through direct, overt, severe trauma. Um, and we'll look at, we'll have to review the stabilizing or the stabilizers of the glenohumeral joint. And I know you've already done this. It doesn't hurt to review it, especially in the context of where we're going next for this, which is looking at hidden etiologies for labral tears. In particular labral tears. So if you're a bit bored with the review, just live through it. It doesn't last very long. Then we'll get to the meat of this to a point. I'm going to do the same thing I did with you last time. Let's leave you with a question. But this time the question is going to be a bigger one that we'll address on the next video. But before we do that, let's look at the last question I gave you about the foot, and we'll sort our way through that, and then we can get started on the shoulder. Okay, so last time I asked you about 5 causes of flat foot. I've changed it a bit here because it needs changing. I should have said 5 demonstrable causes of flat foot, so that you can actually find it by testing and saying, okay, that's certainly there and it may well be what's causing the flat foot. So that leaves out everything, such as walking on hard substrate, taking up running where the foot's breaking down, wearing bad shoes and so on. None of these can be definitively tested, if you like, short of making them do something different and seeing what happens. So mostly this is about weakness of the muscles. In fact, it's all about weakness of the muscles. The muscles that hold the arches up, that is the intrinsics, tibialis anterior, tibialis posterior. So I've got S1 radiculopathy there, but also L4 and L5 because of tibialis anterior and posterior. So a radiculopathy of any of these can result in flat foot. Neuropathies, the tibial nerve and its branches, which is going to cause weakness in the intrinsics and tibialis posterior. Deep perineal neuropathy, deep fibular nerve neuropathy, if you like. Neurological weakness of tibialis anterior. Segmental facilitation, again I've got S1 up there for the intrinsics, but it can also be L4, L5 for anterior and posterior tibials. Fast and slow flow axoplasmic compromise. One cause is in synaptic failure, and the slow flow causes structural weakness in these muscles. So again, the nerve root or the peripheral nerves and their branches that supply intrinsics, tibialis anterior, tibialis posterior. Reflex inhibition, which is neurophysiological weakness, obviously. So now we're looking at a problem in the foot itself, weakening the intrinsics, or possibly a weakness of the ankle, which is going to weaken or may weaken tibialis anterior and or tibialis posterior. And again, these are not going to hold the arch up, and then the intrinsic muscles are not going to be strong enough to do it by themselves, and the foot collapses. And then also simple failure of any of these muscles, just not able to withstand the stress that's going through them, probably because of a tailored subluxation. Just it cannot cope with that, so it gives way under that stress and the foot flattens out. Eventually that will almost certainly change to degeneration and then degenerative tearing. But there's 8 possible causes, all of which can be demonstrated by clinical testing. So as promised or threatened, depending on your perspective, we're going to have a quick review of stability of the glenohumeral joint. First off, there's a law that basically says that the closer in size the 2 articular surfaces are, the less movement exists at that joint. So a good example of this is the sacroiliac joint. They're almost exactly equal in surface area, and very little movement occurs here, and you see this all the time. So a joint with a wide discrepancy of surface area has huge ranges of motion, and the shoulder is undoubtedly the best example of this. The humeral head surface area is approximately 5 times larger than the glenoid labrum. So this will allow a lot of movement there and a lot of potential for instability. And the stability of the shoulder is not dependent on basically passive constraints. primarily. The passive constraints, notably the labrum, plays a huge role in deepening the labrum so it increases its concavity. Because actually these two surfaces are not very congruent. The radius of the glenoid is much, much larger than the radius of the humeral head. So again, this is a very round surface moving on a relatively flat surface. The labrum and its attachments increase that concavity. So by increasing the concavity, you increase the stability of the joint. But in order to do that, these joints have to be forced into each other. So let's have a look at that. Okay, so dynamic stabilization. This is done by the rotator cuff muscles and the long head of biceps. In fact, the long head of biceps experimentally on cadavers has been shown that if you cut the long head, then it takes about half as much force to dislocate the shoulder than when the biceps is intact. And this is when the biceps not contracting because it's a cadaver. So this plays a huge role in it. But what all these muscles have in common, at least the rotator cuff muscles, is that when they contract in this position, they will pull the humeral head against the labrum. You can see that by the direction of the arrows. And the ones that are most capable of doing this position are going to be subscapularis, infraspinatus, and supraspinatus. They're just going to slam the head up against the labrum. So there's the compression component of this. As the arm moves through range and these muscles continue to contract, different fibers of them and different ones of them are going to play a bigger and lesser role in doing this. So teres major, for example, is likely to kick in when the arm's in a different position than will do supraspinatus, for example. So these are going to be turning on, turning off, depending on where they're trying to stabilize the shoulder through the range. But primarily, these are shunt muscles. They pull the humeral head against the labrum and increase the compression load there. And what this does is, we'll see in a second after we've looked at the inert stabilizers. Generally, this is how we think of the labrum, as a ring around the fossa. It's fibrocartilaginous and it's about 4 millimeters thick, which is about 1/4 of an inch. It's generally described as triangular in cross section, which is true in about 50% of the population. Otherwise, it's variable in the other 50%. So all you can say is that the majority of these are triangular. I honestly don't see what difference that makes to what we have to deal with it. But looking at it, it looks like it's not going to have that much effect at deepening the labrum. And in fact, it probably can't do very much by itself. But when you look at what's attached to it, it becomes a whole different picture. This picture gives you a greater appreciation of exactly what the labrum does. Now, the labrum by itself, as I say, is probably not sufficient to increase the surface area sufficiently or increase the depth of that concavity appreciably. But when it's combined with the stuff that attaches to it, then it becomes a much larger surface area and much more concave. Given that the labrum, the fossa rather, is much flatter, it's a much larger radius than is the humeral head. So without all this on there, this would be like a curved surface rolling over a flat surface. But the labrum plus its attachments increase that surface area hugely, especially when you consider it's wrapping around it that way. So it's a huge expansion on the articular surface and its concavity without losing the range of motion that equal surfaces would demand normally. And it's simply because all of this is very deformable and it allows those movements to occur. Now all we need to do is give some thought to what happens when the compression and its concavity are put together and how it stabilizes the shoulder. Okay, so the diagram on the left side of the screen is showing when everything's working fine. So you've got the pull of the rotator cuff, pulling the humeral head into the fossa. And of course the fossa, when everything's intact, is nice and concave and it will hold the humeral head in place in mid-range under normal forces. So you can move it around. So if, in this case, we're looking at abduction, if the arm is abducted, this won't roll up or slide up as it's being pulled upwards, what it will do is it will skid on the surface and do that. So it's not actually descending on the fossa, it's skidding on that place. It skids in place, and then when you get right to the end, it does start to descend, but at that point, the capsule is really tight, the inferior capsule is really tight, so it pushes it back up again. So it tends to stay in that contact area in the middle of the fossa rather than going up and down as we usually think about this thing gliding up and down. Under normal circumstances, this doesn't glide, except right at the end of the range, and then it's rapidly corrected by the tension of the opposite capsule. That's when everything's working fine. When it's not working well, and you either lose the inert stabilizers or the muscle pull, the dynamic stabilizers, then as you abduct it, it will roll up this thing, or actually be pulled up over the labrum that way. So it can either be pulled up that way, or it can roll up this way and won't skid. So you actually get the reverse glide, which is completely abnormal. So you need everything working together, both the inert stabilizers and the dynamic stabilizers for this system to work properly. Labral instability is mid-range instability. Ligament instability is end-range instability. And you really don't want either. But if you can damage the ligaments and provide the labrum's intact and the muscles are intact, then you're going to get maybe a unidirectional instability, but the mid-ranges will be okay for the most part. Okay, so how do we measure destabilize this short of overt severe trauma? You weaken the dynamic stabilizers, which includes biceps long head, infraspinatus, supraspinatus, teres minor, and probably in certain conditions, teres major. Anything that pulls the humeral head or pushes the humeral head into the glenoid. Or you can damage inert stabilizers through overt trauma, which is really quite obvious in the history, that there's a major damage to the joint, or by repetitive stresses on top of, usually on top of hidden etiologies, which will weaken those dynamic stabilizers and the labrum and the capsule and ligaments. So your job for next week is to figure out why, how you would weaken these muscles, what mechanisms would do it, and both the rotator cuff muscles, biceps long head, labrum, and the joint capsule and ligaments, and figure out just how this stuff gets weakened. You've certainly got enough information from the previous module. You need to be thinking again, mechanical versus neurological versus neurophysiological. All of the stuff we've been talking about for the last 4 weeks or so. So next week we'll discuss this, and that should make an entire video up. Okay, do yourself a favour, don't short shrift yourself on that little test at the end of it. I'm going to cover it next week, I know, but you doing the exercise will give you much more benefit than me just walking you through it. Work at it, fail at it, succeed at it, but do it. In fact, the more you fail, the more you learn from your failure. But get on with it. You'll learn much more than just simply listening to me. Anyway, I'll talk to you again next time. Take care all. Bye-bye.